Examining Healthcare Abroad, next on International Focus.
The Institute of World Affairs at UWM and Milwaukee Public Television present International Focus, a global magazine linking Wisconsin and the world.
Welcome to International Focus. I'm Doug Savage, Assistant Director of the Institute of World Affairs at UWM. Americans spend a whopping 16% of GDP on healthcare, double the figure for many other wealthy industrialized countries. Yet outcome indicators like life expectancy and infant mortality are actually better in many countries that spend less per capita on medical care. Is this the proverbial case of apples and oranges? Or are there lessons to be learned from other nations as we debate the future of healthcare in America? To help us diagnose some of the world's alternative healthcare models, we're pleased to be joined by Scott Adams, Associate Professor of Economics and faculty member in the graduate program in Human Resources and Labor Relations at UWM. He recently served as senior economist on the President's Council of Economic Advisors. David Hekman, Assistant Professor of Organizations and Strategic Management in UWM's Lubar School of Business. His research includes methods to improve the quality of care that healthcare organizations provide. And Robert Kraig, Director of Program for Citizen Action of Wisconsin and a leading activist in the national debate over healthcare reform. Well, welcome everyone.
Thank you. Thank you.
Well, I'd like to begin with just a sort of a fundamental question as we look at healthcare systems around the world. Is there an American healthcare system?
I don't think there is. I don't think we have a healthcare system. I think it's a leaky patchwork of subsystems that excludes 15% of Americans. Unlike Canada, which has a national health insurance system, or the UK, which has a national health system, which actually incorporates the payments and the hospitals. We have HMOs, PPOs, we have a clump of doctors over here, a pile of nurses over here, and payers over there. And unfortunately, many people are excluded from the system.
What do you think, Robert?
I mean, we don't have a unified system like they have in Western Europe, Canada, Japan, or Taiwan, for example. We have a number of different systems that are not well integrated at all. We do have an employer-based healthcare system. It's at least a social compact that people used to get healthcare through their employer and the benefit wasn't taxed, but that's atrophying and is under huge pressure because of healthcare hyperinflation. We do have a Medicare system for people under 65, which is similar to the Canadian system. As we were talking earlier, the VA system is more similar to Great Britain. So we have some different systems that's not fit together in one unified system, and it's not working very well. So it's very costly for below average outcomes.
Right. Yeah.
I think well integrated is the key word. I think that other countries have had to make do with a combination of public and private systems, but have done a better job of integrating them and ensuring that you did not have this large group of people that go without health insurance as we do in the United States. And that's the fundamental difference. I think there's a bit of a misconception that every other country out there has this centrally planned government-run system. I mean, most countries have, with the exception of, I'd say, UK and Canada, most other countries have, and even the UK now has quite an extensive private health insurance market. But most other countries do rely on private market principles as well to run their healthcare systems.
Well, what is the historical sort of accidents that created the American system as it is? I mean, why was there no centrally planned or sort of unified integrated system here, do you think?
I think it started with World War II price controls and wage controls that we wanted to ensure that companies here weren't paying workers more than we're fighting overseas. And we had wage controls, and employers used tax incentives offered by the federal government, the tax code, to offer their employees health insurance benefits that they didn't have to pay payroll tax on. They were able to attract employees. That became a very good way to compensate employees more and attract better employees. And the healthcare system that was employer provided, this tax incentives from employers to provide healthcare, has just continued to exist generation after generation. I mean, eventually we realized that wasn't working very well for the older population. Medicare was put into place. We realized it's not working very well for the poor population. Medicaid, followed by S-chip programs, went into place, but we haven't quite figured out any way to integrate a system for those people who lose their jobs, who are between jobs, who for whatever reason think for a short period of time they can go without health insurance. That's kind of what's ultimately led to this mess that we have now.
And how big a portion of the economy is healthcare writ large?
It's huge. It's massive. 16% is what you just said. I've heard 17%. Also, it's a big reason why people go bankrupt. 60% of bankruptcies are due to healthcare in this country. And the thing is, most people don't realize this, but they're just one major illness away from going bankrupt. Because those 60% that went bankrupt, 75% of them had health insurance. But if you're sick sick for long enough, you're still going to go broke. So it's a big deal. It affects each of us. It affects our health. It affects our financial health, our physical health.
And how does that compare to other countries? I mean, just at the macro level. I mean, how big a portion of the economy elsewhere is healthcare?
Well, it's usually half as much and even less in some countries. So we have by far we're up to 18% apparently of GDP now with the recession. The rest of the economy is shrinking a little bit, and we're on a trajectory to be 20%. I mean, in a few years, very soon. And this all we have an historic ambivalence towards government in the United States, and so even though we're one of the earlier countries to talk about national health care reform, Theodore Roosevelt did in the 1912 election as a bull moose candidate, we've never been able to successfully implement one national healthcare system. The other major countries in the developed world have done so one by one. Some as late as the 80s and 90s, others much earlier than that.
Right.
And so, and we still have those sort of ideological hang-ups where we developed what was for a time a very successful private-based, employer-based system, as was explained a couple minutes ago, but it's atrophying under the pressure of hyperinflation. We've had a doubling of health insurance premiums since 2000. We'll have another doubling by 2016 if we don't have fundamental reform. And we have just terrible problems with a very system that doesn't promote very high-quality care in terms of integration, chronic disease management, preventive care. So in other countries, they all have, a lot of them have, as you point out, a lot of private involvement in the system. Germany or Switzerland or Japan have private insurance, it's nonprofit, but they tend to have much tighter controls over pricing. They have some sort of system for nationalizing what the price will be and controlling that over time. They also have guaranteed access to affordable coverage in various ways and subsidies for people to afford that coverage. So even in a place like Germany where they have private insurance, it's nonprofit. People choose between 242 different insurance companies that are nonprofit, but there's also premium assistance, and the employer picks up the rest if you're employed. So it's a much more functioning universal system, and with different variations, it works that way from Canada to France to Japan to Great Britain. There are differences. Great Britain is the most socialized on the scale. Switzerland and Germany and Japan are more private, but have a lot of price regulation, have guaranteed access and affordable premiums.
So to what extent do you think these various systems are reflective of some deeper cultural issue?
Yeah, I worry that this is all part of the massive inequality that we have in the United States that pervades not only healthcare but education, and a lot of these cross-country outcomes that you see in life expectancy are likely driven by sort of our ambivalence to fighting poverty in this country, and I think that plays a big part in the fact that most of the other countries, while it is true that if you have employer-provided health insurance in the U.S., you have access to more tests, you have access to higher technology, but there's really not a whole lot of difference in terms of preventive care, in terms of primary care physicians, and that attitude that other countries have, that there needs to be a common baseline health for the population is sort of something that I'm not going to say that our entire country doesn't buy into, but I don't think we're quite to that level yet, that we're willing to perhaps give up a bit of our own very generous health insurance plan to ensure that the population has health care that's not rationed on the basis of income as it is now.
Well, one of the sort of criticisms you hear when we look at systems abroad is, well, it's all just socialized medicine out there, and it's all the big government rationing care. And in fact, there's actually quite a range of different approaches around the country, isn't there, or around the world, rather?
Yeah, there's basically three, right? There's the Canada's model, which is insurance. The government does the insurance. So the government pays for the health care. The doctors are still their own private practice. Then you've got the UK model, which is everything. And the UK model happened after World War II as well, where, after World War II, the government had already been running all the hospitals and running the health system, and so nothing changed when they decided to make a national health system. It's like the VA, as you said. And then you have Germany's system, which is essentially the employer. The employer pays or subsidizes everything, which is what, for Americans out there, if you've got employer-subsidized health insurance right now, that would be the model. So there's three: the employer-subsidized, the government pays everything, or is the payer, and the national system. The government runs everything.
I'll add one more to that, and it's sort of a similarity between the German system and the American system that people don't quite appreciate. If you're being provided health insurance from your employer, a lot of Americans think this is some free benefit that's being given to them by their employer. Right. That's not true. I mean, there's ample evidence that wages vary based on health insurance benefits that are given to you, and that's true. I mean, it's going to come out of your wages. So either the employer provides it to you, but if it started to be provided in another fashion, people would see their wages rise as well. I mean, it is a reason why real wages have been kept down in the United States for many decades. I think I'll add another model, and it's the Swiss model to health insurance, which is something that many people in the United States would probably jump at the chance to try. It's almost I'll step back by calling it a completely free market type healthcare system, but it's a system where people pay for their own health insurance, and it's not tied to their employer. But they ensure that nobody pays more than 10% of their income for health care. So it's sort of subsidized on your ability to pay, and then you have that separate component where the government sort of steps in along with the canton governments to sort of regulate fee schedules, regulate what has to be put in every healthcare package for somebody to have healthcare. And healthcare is mandatory in that country. You can't choose not to have healthcare. So you have another key component. You pool everybody in the population, healthy, not healthy. They're all part of the same pool. You don't have the adverse selection problem that could cause health insurance prices to rise so quickly. And it's a system that I think has a lot of appeal if the U.S. could get around this government regulating what's in the basic benefit package. That is going to be the sticking point.
Okay, well, we'll continue this in just a moment. Right now, we're going to take a short break. We'll be right back with International Focus.
The Institute of World Affairs presents our community with a range of public programs relating to global issues, U.S. foreign policy, and the world economy. For more information about the Institute of World Affairs, call 414-229-3220 or visit our website at www.iwa.uwm.edu.
Welcome back to International Focus. We're talking with Scott Adams, David Hekman, and Robert Kraig about healthcare around the world. Well, when we left, we were talking a little bit about the Swiss system. Now, they actually made a very purposeful decision to implement the system they did they not? I mean, there was sort of a national referendum, and
it barely passed, actually.
Yeah.
It was highly contentious. I think it was 96.
Yeah, 94, I think.
94.
But it was very, very close.
Yeah.
And so they were like us. They'd had a system that had grown up in a more haphazard fashion. They decided to get control of it. One thing, they're the closest to us in terms of they're the second most expensive healthcare system in the world, but they have much more affordable care. They've taken what makes them similar to Germany or Japan or the other systems that are private is they've taken the profit out of it, and that these are all nonprofit health insurance companies. They can't cherry pick based on age, pre-existing conditions, other risk factors, they can profit for supplemental care. So they can do that. But they've taken the profit out of the whole system, both for insurance and for drugs as well. And so that helps keep costs under control. And that's something that, that's part of the big debate right now in the United States, whether we're willing to go that far, is in question right now as we tape this. And we have a uniquely for-profit health insurance kind of business model in this country that has done a lot of things that the other private insurance companies that national healthcare systems were built upon in other countries didn't do. So it's much harder to build a healthcare reform plan around that kind of health insurance business model.
Well, and that really is fairly consistent throughout most systems in the world, that the profit motive has been taken out of it, has it not?
Well, I would say much more than the way the system has been built up here in the U.S. Although there certainly are elements of other systems, the private markets that have developed around other public insurance options have private components that are for profit as well. But the U.S. I think is unique in its level.
Well, in many places where there's a relatively low portion of GDP accounting for healthcare spending, is there not a situation where oftentimes the healthcare systems are running deficits annually?
That varies. Certainly, the French system has run deficits. I don't know much more country specific. Notoriously, struggling with rising healthcare costs is not an American phenomenon. I mean, it is true that we spend a lot more of our GDP on healthcare, but some of that has to do with the fact that we choose to do that. Healthcare is a normal good, as we say in economics. As the income goes up, you buy more of it. What worries me more is the inefficiency that exists in the U.S. Even we don't have to look across countries. We can even look at Medicare spending across locations in the U.S. I mean, so Medicare spending per enrollee is much more expensive in Miami than it is in San Francisco, and there's almost no reason to suspect that would be the case. And there's also really no different services that So there's a lot of there's a lot of potential inefficiencies that we really have to get a handle on in our system.
And where the systems are more efficient, how is that accomplished?
There's more IT in other countries. Fewer. They certainly have. It depends on the country, but fewer medical errors. You don't quite have this patchwork of healthcare provision like we do in the United States that leads to inefficiencies. Plus, you also have different incentives for providers in the U.S. than you do in other countries. Providers of care in the U.S. Don't necessarily have the incentive to keep costs down. All their incentives ultimately are keep their patients as happy as they possibly can. Their patients don't have cost sharing to a large extent if you talk about those of us with very good health insurance plans. So the fact that we don't have consumers really bearing as much of the cost burden of the system sort of leads our healthcare costs to grow a bit as well.
And I can just jump in with a personal example. My wife's a physician. She had a patient 2 weeks ago in the ICU, and this just shows how we have a disease care system, if we have a system at all, rather than a healthcare system. He's a diabetic patient, 49, security guard, recession. We all got hit by the recession. His hours got cut. He lost his health insurance. So he's diabetic, and he has to just guess now. He can't afford these diabetes strips to monitor blood sugar. $3 a day. But he's making $7.50 an hour, and he gave permission to use this story. So he can't afford it, so he has to guess how much to do to monitor his blood sugar. He's wrong. He gets sick, he messes up, and he ends up in the ICU. Ends up with a stroke. He goes into a coma. He has a massive heart attack, all because of $3 a day. And so they end up spending $5,000 a day for 2 weeks. That's a lot of money. That's about 200 years worth of strips, of diabetes strips. So that tells you, that just shows you how, it's a very good example of how our system is inefficient and it's costly for these silly reasons. Universal, this wouldn't happen in Canada, this wouldn't happen in England, Germany, if he just had access to insurance.
Yeah, I mean, and Scott mentioned this, but the Dartmouth Atlas has done 30 years of research on our healthcare delivery system. They've been able to do it because of Medicare, because we can look at the same service in different hospitals, different cities across the country. And the conclusion is that the variable on how much is spent, there can be as much as a 10-to-1 variation between, say, La Crosse, Wisconsin, and Miami for the same diagnosis. And the variable is how many specialty units there are, how many specialists, how many hospital beds. And if you build extra capacity, it gets used, and we build a lot of extra capacity that gets used for outcomes that are slightly worse. That's the other Dartmouth Atlas finding. And so they conclude there's about a third of medical spending in the United States which is not value added. I mean, that's hundreds of billions of dollars that could potentially be saved. So that's how we can spend double the GDP and not cover everyone.
And have worse quality.
Right. Don't do chronic disease management, which is a huge cost thing. Don't do good preventive care. The payment system is messed up to the point where we encourage all sorts of billable acts like tests, like a procedure, but not the basic case management and the coordination that would actually lead to better outcomes and lead to lower cost, and just the chronic disease management like you were talking about. And so it's an extremely costly system that we can't afford anymore, not only individual families, but government and business. And the copays are going way up. The tradition has been that people had the premiums and not many copays, but people are doing a lot higher deductibles and co-insurance and co-payments for everything right now, because there's nowhere else to get the money other than to push more cost on to individuals.
Sure, and it's not. The worst. It's not necessarily based on income or your ability to pay.
It's the opposite.
It's the opposite. It's regressive, where in other countries they base their copays more on your ability to pay, and that also helps keep costs down. So it's like we have elements of a system but not one that works to reduce costs or cover everyone.
Right.
You know, we've talked a little bit about the various systems from the patient's perspective. What about the physician's perspective in different models around the world? You know, that's one of the criticisms we sometimes hear in this country, that, you know, you have a system that doesn't really compensate doctors adequately, and, you know, they're not particularly happy. Is that?
Well, certainly it's not the case in Switzerland. They don't have physician shortages. But in some of the other countries we've been mentioning, they do have trouble with physicians being happy with their payment. There have been examples of strikes.
Because in many systems, they're very clear and government mandated compensation for various procedures, aren't they?
And there's no doubt that U.S. physicians make a lot more than physicians in other countries,
specialists make a lot more. Family physicians is fairly comparable, at least between the U.S. and Canada.
Well, it might be true between the U.S. and Canada. I'm not sure about that, but I certainly know, compared to some of the other Western European countries, they do primary care physicians in U.S. are off. But yeah, I guess the idea is it's not necessarily about primary care physicians, because they're probably not the first ones who are arguing against having a different system in the United States of healthcare provision, because, you know, primary care should be where a lot more of the focus is put. I think there's a lot of. I think certainly the physicians would have a lot to lose from moving to one of these other systems.
Although my wife is for it. She's a physician, and most of her colleagues are in favor. She's a family physician, so that makes sense. But the specialists are.
And I'm sure many specialists are, but they certainly are putting up. They're trying to put up their own proposals, too, that have merit. It's a complicated. There's no exact one-right system, and we have a lot of tradition in the U.S. and very good physicians and very high-quality medical care for those of us who have access to it. So there are plenty of people who would have some to lose to move to a different system.
And they still make good salaries. I mean, they make 120 to 180 thousand a year. We're not going to get down to 8% of GDP. So with the waste we have, we could probably keep paying physicians what we're paying them and still save a great deal of money in a different system.
Well, you know, we mentioned Switzerland, for example, made a decision to implement these sort of whole-scale changes in the way they did health care. What do you think are the institutional barriers to doing that here? I mean, what is standing in the way?
Well, the for-profit insurance industry has much more to lose than doctors. The AMA is actually supporting the current House bill, which is the best example of Obama's reforms right now. The drug industry as well, it makes very large profits, so they're a huge institutional barrier. And then I just think
they're supporting it too.
They are now, but they've been holding their $250 million war chest up as kind of extortion to try to make sure it doesn't gore their ox.
And we'll back up a second, too, and say the Obama a plan is nothing like the models in these other countries. And maybe that's something the general public needs to know. It's not really changing fundamentally how we get our health insurance.
It's a much more American approach, trying to learn something from these countries.
So it's should be much more palatable to these interest groups.
It should be.
Yeah.
But then there's huge political resistance to this. I mean, and ideologically, there's so much inhibition about government intervention in the economy at all in this society that's part of the reason we don't really get this done, is that culture of kind of being against the government that we created as the first large-scale republic. It's an odd kind of thing for foreigners to understand, but we have a real problem with our own democratically elected government in our political culture.
And compared to Germany, it's a lot harder to get things changed in our healthcare system in the U.S. than it would be if we set up their system and constantly changing what's mandated in the packages, what the central government that does the central body that does cost effectiveness analysis for different care. That sort of really fundamental, important things to have, that we ensure we're rationing care based on the quality of it for everyone rather than on income and cost. Those sort of changes we need is something that just in the United States we wouldn't want to put that much control in the federal government.
Well, Fred, we'll have to leave it at there. This is certainly a topic that we'll be hearing more of in the months ahead. But in the meantime, thank you to our panelists, Scott Adams, David Hekman, and Robert Kraig. To our viewers, we'll see you next time on International Focus.
For information about the Institute of World Affairs and its many programs, or to become a member of the Institute, call 414-229-3220 or visit us at our website.